the biomarker story is a two-stage story. There's the first generation of biomarkers and the second generation. The first generation of biomarkers in urothelial cancer has been extremely confusing, and the inconsistency and the inconsistent inconsistency, even within single drug programs where the biomarker doesn't work second line and does frontline, this needs to be addressed. So before we move on and let these biomarkers go, I think we do have an obligation to find out what we're doing there. And we can do that with the frontline trials. We've got 5,000 patients in frontline randomized trials, all of which are doing biomarker analysis. So we will be able to clarify this issue over the next year or two. And just when a game of chess appears incredibly complicated, it can be very much simplified by one or two simple moves. And these trials reading out will be part of that. We will know a lot about frontline biomarkers. And in fact, the EMA and FDA have told us the frontline biomarkers seem to work. So let's not throw away PDL1 yet. I think we're going to be using it. And then the second piece is the second generation of biomarkers, which a year ago we all said would supersede the first generation because the first generation wasn't working well. I no longer believe that to be the case, but I do believe that tumour mutational burden, some specific signatures, EMT, APOBEC, TGF-beta, these type of signatures may herald sensitivity and resistance, and they may facilitate and allow us to build a biomarker platform where we can be increasingly confident that we're selecting the right patients for the right treatment at the right time.